Good evening, everybody, and welcome to today's episode of Marvelous Medicine, which is on the digital revolution in healthcare. Talking today will be Dr. Shivam Natarajan. He's the director of SP Healthcare Solutions Limited, a healthcare consulting firm in the UK. His current projects include being the senior advisor to the Ministry of Health in the Kingdom of Saudi Arabia, and he's also developing the digital strategy for Leicester Integrated Care Systems in the NHS UK. Shivam did his MBBS and MS General Surgery from JIPMER Pondicherry. He did his MBA from Madras University and has several licenses and certifications in design, innovation, data science, and clinical research. And if I have to read all of them, we won't have any time to listen to his talk. So Shivam has over 30 years of experience in delivering healthcare transformation programs in many countries. He developed Asia's first virtual medical university way back in 1998 and was the vice president of Apollo Hospitals Group and director of Medvarsity Online. Many of the youngsters will know him as the author of the Shivam MCQ books for both undergraduate and postgraduate entrance exam. And Shivam is probably one of the few undergraduates in JIPMER of the 80s who started publishing while doing before completing his post-graduation. So welcome Shivam for immediately accepting our invitation to deliver this talk. Moderating the session will be Dr. Suman C. Raman. He's welcome again to Marvelous Medicine, Suman. Everyone knows that he's a television anchor person, commentator, political analyst, doctor, and obviously some of you didn't know that he was also a healthcare IT professional. He's a co-founder of the health portal www.webhealthcenter.com. He's presently involved in a startup in the area of AI-based clinical decision support systems. Suman did his MBBS and DCH from Madras Medical College and MD Medicine from SRMC Chennai and has a diploma in computer applications. He has been involved with some of the largest IT implementations in healthcare IT space in the area of HIS, EMR, eHealth, telemedicine, CDSS, and health portals in both the public and private sector. Needless to say, he's delivered several lectures in national and international conferences. The person behind this program actually is my ex-colleague, Dr. Vishwarup Pal. He suggested that we should do a session on electronic health records for Marvelous Medicine. And when I reached out to Shivam, he said that may get a bit too boring. So he'll speak on the broader topic of digitalization of healthcare. Dr. Pal is a clinical lead, critical care services at Fortis Vadaparani Hospital in Chennai. He's also a consulting partner in an MSME IT company in Hyderabad, providing SaaS-based HIS for MSME hospitals. Dr. Pal did his MBBS from Calcutta University and MD Anesthesia from Bombay University, after which he did his postdoctoral certificate course in cardiac anesthesia and critical care at Madras Medical Mission, Chennai, and almost became a Chennaiite. He has been in leadership positions in anesthesia and critical care in several hospitals across the country. He's one of those who doesn't hesitate to call a spade and is always looking forward to innovations and change. Welcome, Vishwarup, for suggesting this program and for joining in. Over to you, Shivam.
Thank you, Vidya. It's a real honor and privilege to be here. And once again, thanks to you for inviting me. And I should acknowledge that I am in the midst of quite an august sort of audience. So bear with me if I'm not able to get up to the expectation that you've already set on the agenda. But what I want to do before I even start is I want to acknowledge and I want to pay tribute to all the teachers, especially Dr. AK, who's been my sort of guru, I think, from undergraduate, right from I started doing my first project with him from third year of MBBS, I think, and I do miss the academics, so I don't know how he's going to respond. So in the morning when I heard him, he's already started inquiring who's this Subbu who's going to talk. I thought I have to get ready for ward rounds, the good old days, can't remember how much the youngsters of these days respect the ward round. But we used to be there at 7:30 after going home at 7 after our whole night duty. So within 30 minutes, you have to come back. And I used to have senior residents like Kate, Ravindra, and all of them used to put me in the front and say, Shivam, okay, you manage it now in front of it. And so, you are always ready to meet the barrel, double barrel or single barrel, you don't know. But what it taught us was discipline. And the two things I sort of took away, I mean, as you said, unfortunately, after the 20 or 22 papers I published with Sir, to be honest, I didn't do any publications after that till possibly 1997 or 98. So there was a huge vacuum, 2007 or 8. So I do miss the academics. I do miss being a surgeon. But that doesn't mean that, as a doctor, you don't contribute to society. So that's possibly what I wanted to bring out most in today's talk. Very often we shoehorn ourselves as healthcare professionals, and we get stuck into that silo that, as a doctor, you do only healthcare and not, patient care. And there is so much to healthcare other than patient care, and hope today's talk will show one dimension of that. I'm in no mean an expert in that, although I've spent almost 22 years of my life in digital health. I don't consider still, I've just scratched the surface is the right word. It is such a vast ocean, and it is so rapidly growing that it is impossible for any single individual to have the understanding of the breadth and depth of digital healthcare today. So hopefully my ambition today in today's sort of discussion, and that's what I labeled it that way. I hope you're able to see the screen, Vidya?
Yes, sure.
Okay. So why I labeled it as know the big, adopt the small, and grow the whole. I just wanted to give a little bit of backing around why I titled it this way. One of the challenges for us as a doctor is we get stuck with that doctor-patient relationship, and we see what we see in front of us. We hardly get to see what is behind the scene, and we don't usually spend much time thinking about it. So what I wanted to show today is when you're sitting in front of your patient and you are having a digital experience, or if a patient is having a digital experience, there's quite a lot that goes behind that. And understanding that is very important for us because we need to contribute towards that eventually. And as doctors, I don't know, even now, there are very few who enter healthcare technology and digitalization. At least in the last 10 years or so, I have seen a much more greater number of people entering this field. But way back in 2000 or 2000, early 2000, we didn't encourage clinicians entering into healthcare technology. And that actually was one of the major reasons why technology is not so well adopted in medicine. So one of my sort of ambition all through my last 20 years has been to mentor as many people and encourage as many clinicians to bring them into healthcare technology. And I hope I've done some justice to that. But I think we are still sort of lagging behind that. As a doctor, if we don't take responsibility for this digital health ecosystem, we are going to fall prey to administrators and IT guys dictating it to us. And that's when we start saying, oh, it's not up to your liking, or you don't like it, or you're not engaged in that process. And the reason for that is we ourselves have stood away from this field. So hopefully at the end of this discussion, one of the things I want to do is actually make sure that we encourage people to get into healthcare technology. Last 4 years, I've managed to get Nala encouraged. So which means it gives me hope that if I can get Nala to think about technology, then others will surely be encouraged for that. So that's knowing the big. And when I say adopt the small, what I meant is, I mean, healthcare technology is so vast. So we don't need to actually know the entire big picture always, but we can take what we want from it and we can specifically use it for what we want. And therefore, adopting even a small part of it gives us a great return on that effort. So I wanted to show where adoption is today in healthcare technology and why we have to take part in the adoption of technology. And what I meant by grow the whole is every one of us has got some role or the other in healthcare technology, because fundamentally, when we talk of health, digital health, what underlies that is data. And every single word we write in our EMR today, or in your patient discharge summary or your prescription, even the date and time is valuable data in healthcare. And that is why I say that everyone can contribute to the big picture of digital health. So that's sort of the theme, and hopefully I'll do justice to it. I've sort of arranged it in 3 sections. One to talk about digital health ecosystem, the other one to talk about barriers, but I've moved my sort of presentation. I will do barriers towards the end, and of adoption to the end, and I'll bring what the future looks like to the front. I hope Sumant and Biswaroop will be able to add in as we go along. My intention is to give, and I want it to be a discussion rather than one way. So if people don't ask questions, I'm going to be asking questions. So you guys have to bear with me. I mean, as I said, the only thing I learned from my, I think it's 7.5, 8 years of lessons with Dr. Natarajan was at least ask the right question. And then, if we get answers, that's okay. If we don't get an answer, that's still okay. But at least if you don't ask the question, then we are doing a gross injustice to our lessons and our learning. So bear with me if I ask some questions. And on that front, we're having the first question. Pata or Vidya, you are planning to do this as a survey, or how do you want me to do, or should we just show the question? Oh yeah, so in front of you, you would all be getting a question. I want you to vote on the first question. Is IT and digitalization in healthcare is a waste of time and money? If that is the statement put to you, can all of you go and click one button? Just take the first question only today, now, and we'll do the second question later. I'm going to do it myself to check whether it's working, but the others can possibly add to it. Shall we give?
So you can't submit unless you answer both questions. So
okay, then maybe go ahead and answer both of them, and we'll do both of them during our discussions. The second question was, do your patients have a digital health record of some kind or not? So should I give another 20 seconds, and hopefully all of you have the ability to vote on that. And thanks Vidya and Pata to have done this effort for me to put it as a poll, and maybe somewhere you will be able to see the numbers and the results, and you can possibly tell.
Radhakrishna, you have the results? Anyway, thanks to you, we read about this option of Zoom. So even before you started the talk, both of us have learned one lesson today.
So it's good. It's good to.
Can you see the?
Yeah,
I can see the thing, and I can already see such poor adoption. Or is it? How many have answered it? But I couldn't see the total answer.
100% answer.
Oh, very good. Thank you. So at least adoption here is 100%. That's good. That's good adoption of technology, at least here. So we've got a very engaged. No, let's take a look at it for a minute. So great. Strongly disagree on IT and digital, but 16% strongly agree that it's a waste of time and money. And then in terms of only about 40% of at least people have not had a patient having a digital health record. Okay, thank you. So the reason why I wanted to actually start with that debate is we can see that it's a debate already. People have this polarized view about the cost of healthcare versus the cost of healthcare IT. Today, healthcare is such a political agenda, both at national and local levels. And sorry, someone's.
Yeah, we muted them. Go ahead.
Okay. So I just wanted to say that, cost is such a big issue in healthcare, and when you want to spend so much on digital healthcare, there is a huge dilemma among administrators. Do I spend on the next theater? Do I spend on a laparoscope? Do I spend money on building one more clinic, or do I put the money into an IT system? So that has been a big question in many hospitals and administrators, and particularly when I work at national level and working with governments, it's a huge question. And the only way you can answer it by is showing the benefit of it, right? And showing the benefit of something which is so pervasive in everyone's life is often very difficult. To say that, look, if you spend $1 billion into IT, you get $1.5 billion benefit. That's been a very difficult equation. And this has been one of the biggest challenges, actually. We don't have a lot of publications in this. There's not much of a scientific literature which is published on that yet. So that's one of the reasons why that controversy continues. Yes, I heard some question.
Shiva, can I just talk about,
yes, please.
mention something about this cost?
Can you just hold the mic a little closer, Paul? We can't hear you properly.
Yeah, can you hear me now?
Yes, we can.
Yes. Yeah, so regarding this cost, until actually it is numerically pointed out, people don't realize. So for example, the hospital where Radhakrishna works, it's a 250-bed hospital, roughly, I'm just saying, or 300 beds. For a 300-bed hospital with approximately 250 occupancy at all times, with a OPD footfall of at least 400 minimum, otherwise we can't have 250 OP-ER footfall, and then labs and entire administrative backup. The total cost usually works out to, for every 100 beds, 3 lakhs worth of stationery per month. Okay. This I did this homework when I first started going around marketing my product on my regarding my company. So until I actually showed that if you are talking about numbers and mathematics, this is what you are silently spending per month, and then spending a huge amount of money to store them, preserve them for next 7 years. So that is the direct mathematics. As far as qualitative benefit, that translation, that possibly is not as mathematically provable as you were saying. Thank you.
That's a very important point, Viswarup, you made, and we'll come to that. See, one of the sort of traditional way of thinking about the benefit of technology was actually what you gave as an example. Does it replace paper? I mean, it's not just the loss of paper that we are talking of in technology, and that's where, if I've done a lot of work around what we call as benefit realization in healthcare technology, and one of the core areas that I work is actually bringing forward the benefits use cases. We call them as benefits use cases. Sorry if I use a lot of technical language because I'm in the midst of a lot of doctors, so bear with my terminology, and if I've sort of steered away from medical jargon, I'll try and keep it as non-technical as possible. But I will come to that, and one of the biggest sort of benefits use case now is actually in what we call as cost reduction in healthcare operational activities. So your efficiency of healthcare, your safety of healthcare, your ability to avoid complications, those have become the bigger sort of benefits realization use cases for technology compared to even hard things like stationary replacement. The other biggest benefit is what I'm going to possibly show in the next slide, is what we call as the patient experience. We are all running private. I mean, I see a lot of people from private and public enterprise, but irrespective of whether you're in private healthcare or public healthcare, the patient has to be at the center of everything that we do and we think about. So when you think of the patient today, there are sort of two big areas as a clinician that I look at. One is to look at outcome. Have I done good to the patient? Have I created good clinical outcomes? And definitely technology plays a huge role in clinical outcome. But the other side of the clinical, the patient, is the patient experience. And when I come to some later slides, I will show how technology does or does not impact experience. The role of technology is first and foremost to make that healthcare journey smooth and a good experience first, and then bring out the outcomes. This is a good slide. I just wanted to show the complexity of the journey and how digitalization is needed in this sort of a complex journey. I saw Pata's sort of, sorry, but I'm calling you Pata actually as a friend. So Dr. Radhakrishna's sort of write-up for today's talk. And there he was talking about queuing and how the experience of queuing has actually disrupted our patient experience. It's not just the queue alone, right? If you look at the number of times we ask questions, number of times we ask the person what they have, each and every doctor asks every same question, and each and every time the patient stands or is in front of a healthcare provider, they are sick of repeating the answers. Very often they sometimes out of memory loss give 2 or 3 different answers to 2 or 3 different physicians, and ultimately the history is never consistent. So the patient experience is very, very fragmented today with the absence of technology, whereas with the presence of technology, what we call as the digital front end. And I'll show you an example of how the NHS digital front end looks in a few minutes. You find that the experience, the health experience is much different. The other thing that what has happened traditionally is we have made healthcare sort of revolve around the physician. It has always become a physician-centric model, particularly in the Indian context, and even in the West. It has always become almost physician-centric rather than the patient at the center of it. So what digitalization has done in the last few years, or at least in the last 10-15 years, is put the focus on the patient much more than the physician or the facility. And COVID particularly made a big impact on bringing out the relevance of digitalization in health in a big way. Now, I'm just going to tell a little bit more about the digital experience and where digitalization is key. This is one of the few papers I've published after coming out of Chipmer, actually. And one of this was a paper which we published with 6 authors from 6 different countries to look at what is the status of health information exchange in 6 different countries: China, England, India. And this was 3 years back. But what I wanted to highlight, so I was asked to comment on, although I was in UK that time, I was asked to comment and write about what is happening in India. There's quite a lot of development which has happened in the last few years in India. We see the Ayushman ABDM or AB, the National Health NHDM, digital mission, so many things. But still, I've got enough. I got my father who is 82, 83, Nalla, 83, 85, I don't know, years old, having Parkinsonism. Every time we get on a call to discuss his dosage, there is no record of it. Then we'll have to say, okay, let's go back and see whether it was 5 tablets, or 3 tablets, or 2 tablets. There is not a single record if he's going to be referred from one doctor to another doctor. He has to, thank God, he's got such a great memory. He's able to tell. You have to rely completely on his memory to understand what his care has been. My mother-in-law, she's a patient with cardiomyopathy. She's with congestive cardiac failure. To this day, when she travels from there to UK, the only thing we get is a prescription slips. She's with a very big, she was in fact with Apollo hospitals in Madurai, and she gets treated there. But when we get to see what is the health record that she can bring across, it's always the bills It's always a prescription, handwritten prescription very often, but in sometimes it's a at least typed sort of record. So the continuity of care today is dependent on the patient or the relatives. You know, we still, I still remember our OPD days in JIPMER. The most literate patient would come with that yellow bag. And once they open that yellow bag, you will have hundreds of papers falling out of it. And if you're diligent enough, you will be able to find a bill with the drug and whatever, and you will then have to infer, okay, this is what the person was possibly having. We did our best in those days to possibly at least give a discharge summary which was legible. My handwriting was not that bad, but we know how handwriting was. So one thing that is still persistent, and at least I think based on Dr. Radhakrishna's own comment, he himself said, look, as doctors, we ourselves do not have a longitudinal health record of our own. When we did this sort of exercise comparing the digitalization of healthcare and health information exchange across different countries, even the UK or the US, all of them have their limitations. They've spent a huge amount of money, but the country which is now closest, I can say, from a digital perspective, I don't want to say that I'm biased towards UK, but to be fair, UK seems to have one of the national level digitally sort of sound environment. And I will show you some examples of how they have managed to do it. Digitalization is happening in pockets in many places. You may go to the Mayo or the Cleveland, or you go to maybe Medcare Hospital in Dubai, and they'll say, look, we have got the best digital record. But what is important is the scalability of it. If you take the average person on the road, do they have any sort of digital record, health record for themselves? It's a question today. And if we look at UK, it has done quite a lot. In fact, what I'm going to do is I'm going to actually share my digital record in UK. What does it look like, to give you a feel for what do we mean by a digital health record, and how does that digital health record make a difference? So bear with me. I'm just going to log into my digital health record and then show that. Meanwhile, any questions, any comments so far? Okay, I'm going to share my screen, which is my mobile phone.
Shivam, can I just, sorry,
Yeah.
this is Ravi Shankar, and if you're confused, I also go by Woody, perfectly fine. And I am Radhakrishna's and Vidya's classmate here. Quick question. So we've been talking about all the plus points about digital, digitizing medical records and digital health, etc. How about, I mean, are there any downsides? And if so, what would that? Okay, sorry, didn't mean to rush you. Thank you.
Yeah, definitely we'll come to that. So I just wanted to say, what does Vidya, are you able to see the screen here now?
Yes, yes.
Yeah, okay. So it's just, you know, I'm okay sharing my digital record. There's nothing to hide in that. But what we can see here is the advantage of this is what I'm showing is the NHS app. Every single citizen who's, or at least everyone having an NHS number in UK have access to this. So everyone who's having a smartphone should be having their digital record. And within that record, they get to see every single encounter they have had with primary care. Again, it's a limitation. What I said is why it is limited. It's only limited to the primary care record so far. We have not yet moved into the secondary care. So if I've had admission, what I will get here is only a discharge summary. But if I've had 100 data points collected during my admission, say I was in an ICU, or if my blood pressure was recorded 20 times, you don't get to see it into this at that level. But at least we have a digital record where all our test results are captured. You have it for you to be able to show it to others. I can actually transmit this to others. It has all my allergies. It'll have all the medicines that have been prescribed to me, all the health conditions that I have, all the consultations that I had. There is an event about it. If there is sometimes an alert, I'm able to see. It also has the ability for me to share my record within my family, so I can actually link my profile. So the mother or the head of the family, or if you're living with an aged parent, you can take responsibility for their record. So there are so many of that capability that exists when we talk of a digital record in the UK context. Now, this important thing about this is a national level program, and every single one of the 60 million odd people in the UK should have it. What was the biggest advantage of this is that we have now a digital data asset that no other country actually has to this size. Singapore has it, but it is a very small country. Netherlands is close to this, but again, it's a very small country. So today, UK has got the richest longitudinal health data for a whole population, and therefore, the power of that data is significant. Just the data monetization, I mean, coming to data monetization can be a very sort of politically difficult thing to talk, but what we are saying is we're sitting on data worth 10 to 15 billion pounds every year, just to put it in more blunter terms. So that's one of the ways of talking about the benefits case, Biswaroop, is every single hospital in even a private hospital in India is sitting on a gold mine of healthcare data and healthcare digitalization opportunities. And I'll show you another example of how I used a very small private hospital to do a digital innovation. So what I'm saying is you don't need to look at digitalization as a burden. It has revenue models built into it. So let us go a bit fast, because I think I'm already behind time. So when we talk of digital health, this is another sort of misnomer. As a doctor, we always think of it as just the HIS system in front of us, or the patient record, or electronic patient record. But digital health is much, much bigger than just that electronic patient record. Today, the digital health spans right from wearables, IoTs. IoTs is Internet of Things, genomics. You take it to AI in health. It has got a vast implication, and the fundamental basis of this whole digital health capabilities comes from the data that we drive as clinicians. So ultimately, it is the doctor-patient interaction, that care event, which is the foundation of healthcare. But that foundation of healthcare is responsible for driving this entire health ecosystem, and both ways. And in my next slide, I will possibly show that. So, and I'll come to that. It's the care event contributes to the technology contributes to the care event. And that's a very important thing to keep in mind. So when we talk of this big picture in health, the reason why I wanted to show this is, don't get bogged down, or don't get sort of have a narrow view of digital health as just your HI system or just a couple of apps on your phone. There is a huge infrastructure that is needed, a foundation that is needed to drive that sort of what you see at the front end. So even when you talk of the big picture in healthcare, you can look at it from a person point of view, the patient, from the healthcare provider, at a facility level, at a system level. If you're a multi-chain hospital, what does it mean to you rather than a single hospital system? At a national level, which I see a lot of work happening in India now, and then even globally. And the pandemic particularly made how relevant digital health is for countries to collaborate with each other. It's not about just collaborating within your country. Digitalization has made it possible for us to have that extensive collaboration across countries. And that's become now almost a critical point in digital health going forward. And there are so many global collaborations now happening on the digital front. Each one of this has got multiple components and solutions. Each word on the right-hand side is an industry by itself. When you talk of mobile apps, today mobile apps is close to about nearly a $1 trillion industry. Patient portals is a very big component of electronic medical records. Wearables, my Fitbit, my Apple Watch, There's so many, our smart spectacles. We have gone into textiles, which are smart now. There's so many areas that we have gone into, which is impacting the health as well as the healthcare delivery. So when we are talking of digital health, there is a huge ecosystem of solutions, technology, manpower, and each one of this is an opportunity for a doctor, a healthcare provider, to contribute as well as use it. And that's the reason why it is relevant for us to actually bring that big picture into picture. I mean, sort of understand that. And I was talking to you about what is behind the scene and how that big picture is relevant for that single care event. So if you want to have in the NHS, so today in the NHS, if I am having a patient with renal failure, going to have, say, a particular infusion at his bedside, there could be at least 15 or 20 different events that are actually managed through technology before that particular infusion happens. The supply chain, starting from the bed end, if you see, the prescription gets electronically transmitted. The timing gets into the nursing chart. From there, the order goes to the procurement for them to prepare the infusion. Then the electronic medical administration record. And then there is a supply chain which understands how much of it is remaining or not. From there, it goes into the cost. And then the administrator understands, okay, am I getting these solutions at the cheapest cost, at the best procurement or not? From there, it goes to a coding. And unless it is coded, we don't get the reimbursement through it. So the care event that we are seeing at the front end as doctors, although there is minimal or sometimes very good digital front end here, there is a huge amount of digital back end to it. Unless that Wi-Fi is good, today hospitals do not function well unless you have a very strong LAN and infrastructure. Hardware is what I'm talking of. You need to have an iPad at the bed end. You want to have the best of digital connectivity between the devices. You want to have a smart infusion pump which says that the last 10 ml is still there and alerts the nurse and calls back. So in order for that event to happen smoothly without much complications, digitalization does a lot towards that. So what I refer to that is that there is a huge team from a digital perspective which needs to make that front end care also happening. So it's always, I always look at when I go for changing the adoption in health systems, we need to recognize that there is a huge technology, and they're always sitting in somewhere in the basement near the mortuary, unfortunately, but poor fellows, they do contribute to your front end work. What is critical about this sort of big picture, right? When we are talking of this sort of a dependency, so if a person needs to have a good electronic medical record like what I showed on the NHS app now, in order for this to happen, there is so many things that is happening in the value chain, as we call it, and one or two of them is key. One is standardization. If all of us do not use the same language in technology, or if we do not have standard approaches to it, each one will be having different systems and they don't talk to each other. So standardization is a big thing, and that's why standardization is the objective of national or global players, and they set the standards, and therefore everyone else is able to talk to each other. The other concept is what we call as interoperability. You can have 10 or 15 different devices, 10 or 15 different equipment, but making them talk to each other is by itself a very big thing. So that's where interoperability becomes a big part of the digital health ecosystem. Each one of this box therefore needs a lot of thought, a lot of design, a lot of research, a lot of development, and that's what is going on in the so-called digital health industry. And the other thing which I was talking about is not just standardization. You don't want it to be a small piece of puzzle sitting only in a small institute. You want this to be scalable. So when you're talking of things like ABDM, they are literally talking of getting some sort of infrastructure to 1.2 billion people, which is a huge effort. And that scalability happens through standardization and what I call as interoperability. But more important is you also have to make it suitable, right? For example, language preference. World over, IT was developed in English, but you may want to have different 24 or I don't know how many languages are there in India now. So, or if I'm doing it in Saudi Arabia, I need it to be KSA contextual. So the suitability of the solution is also important. Your digital front end has to be used by an 85-year-old veteran as well as a 16-year-old teen. You want to engage them in different front ends. So the user interface also has to be thought of. So there are so many aspects to when you're designing such things. This is one of the examples I just wanted to, the Leicester University, so there's a huge program going on in the NHS, what we call as a new hospitals program. In spite of what I was talking about, the digitalization in the NHS, the primary care is quite good. But when you look at the secondary care, only 20-25% of hospitals there is something called as HIMSS maturity. It's like saying, how mature is your hospital in research. Same way, how mature is your hospital in digitalization? It's a score, and if you're around 4 and 5, at least it's reputable. But ideal is to be, not ideal. The top is 7. Very few hospitals are level 7 HIMSS capability. But in the UK itself, only 20% are about 4 to 5 level 5 capability. And the sad part is about 10% of the hospitals are still on paper-based digitalization. So we are looking at taking them into the next sort of era of digitalization, so making them do the big jump. And these are the sort of technologies that we are looking at. We are looking at hospital flow. That is, the flow. You are talking about patients standing in a queue or going from here to there, standing or waiting for their theater scheduling, cancellations happening. How do you ensure that the demand and capacity is managed in your health system? And technology is a key part of that. So flow technologies, we're talking of so many, each one of them is an area. I don't want to go into the technicality, but all I wanted was for us to appreciate that a good functioning 21st sort of century hospital, which is digitally advanced, has got a lot behind it. We've got things to do with patient experience. We've got things to do with virtual care. I talked about interoperability. I talked about integrating care. If I am moving from Birmingham to Manchester and then back to my home, Reading, and there are 3 places where I went from, say, an advanced cancer treatment. One place had radiotherapy, another place had chemotherapy. Do I get to see my longitudinal record? That's my GP who then takes my day-to-day management. Do they get to see the entire journey that I've gone through? Is very critical. So the other big change that has happened in the last 10-15 years is not focusing on the individual. So one of the reasons why possibly I can reveal that here to Dr. AK is why I made that jump from surgery to healthcare technology is in surgery. You always can do only one surgery at a time, right? You can only operate one person at a time. I don't know whether there is any automation that has happened in some fields of surgery. Maybe Dr. Radhakrishna, you could tell, where you can operate on 2 or 3 people at the same time. So I always felt constrained that surgery is 1-to-1, whereas in technology you can reach out to millions, and that gave me that satisfaction. The reason why I'm trying to bring that part is today digitalization and digital health is reaching out to the population. It is not just the individual. We have made the possibility of proactive care or prevention much more efficient today because of digitalization. So we are not in the phase of reactive care when it comes. So digitalization has a huge impact on being proactive and preventive. And that's where the population health management, the public health, there's a huge amount of work happening in that front. I'll sort of skip these things a little bit. I just wanted to focus on this for 1 minute. we are all talking of the environment. We are talking about the carbon footprint. The NHS today accounts for 7 to 10% of the entire carbon footprint of UK. For the whole country, the NHS contributes to 10% of the carbon footprint. Literally, the NHS consumes the same amount of energy and carbon emission as the whole of Sri Lanka as a country. So this is another thing which is part of the European agenda for our, we've signed with COP26 and many other things. So it's a very critical part of our thinking. And therefore, the infrastructure, digitalization is a core part of reducing the carbon footprint in the NHS. And that's another area that we are looking at. I'll pause here. I will wait for some more questions. I had a previous question before I go to the next part of the presentation. Vidya, am I in the right zone? Am I already put people to sleep or?
Don't worry, just carry on. No worries.
Okay. Suman, anything to break the monotony?
Yeah. I think I'd like to add a few very important points more from the Indian context. Of course, also much of this is valid globally. One of the key challenges in a country like India is to show the doctors and the hospitals a significant revenue benefit from using such systems. And I use these systems in a very guarded manner, because today an electronic medical record is not just keying in patient history and physical examination findings and the prescription. It's very much more. It's actually an ecosystem which connects up to multiple devices. I can share a little bit of experience. I spent some time in the UK working on the national program for IT way back about 10 years ago, 9-10 years ago. And they did have huge problems. It is not that UK has reached where it has today. They just started it a few years and then it went smoothly. They had huge problems. In fact, the first program, NPFIT, was actually scrapped, and then it was in a modified form that they actually managed to get things done, and they spent enormous amount of money. But in India, the challenges are slightly different, and you have two problems. First, of course, there is no need for anybody to have an electronic medical record as per law, which we discussed last time, and that is the fundamental issue. The second is a whole lot of issues which boil down to concerns which normally should not actually impact us. And this is like one of the very common questions that I would get asked is, how do you delete a record? Which is not something that any good electronic medical record system should actually allow you to do. But in India, and I'm not talking about a small nursing home owner asking me this, the biggest corporate hospitals in India very often ask us this question, and then they will look knowingly and say, look, there are issues, problems, and so on. So one, there are concerns about, am I going to create more problems for myself by having an electronic medical record? This is a very valid question, because I keep getting asked this question at almost every alternate organization that we used to pitch electronic medical records. We would be asked such questions. So I think we have to work on the human angle here. The second point that I wanted to actually sort of put across is the EMR is no longer in isolation. And the value of an EMR is, if you don't use it at point of care, if you are not taking treatment decisions based on it, then you are deriving roughly 10% of the overall value of having an EMR. Unfortunately, most hospitals in India that I am aware of and I have interacted with effectively use it as a repository. Instead of maintaining a manual discharge summary, there is a typed summary which is available. The lab reports are available in the system, but very rarely is it used at point of care for decision making. The last point I wanted to add, and I'll come back to some more points after Dr. Shivam completes. The last point that I wanted to add here is the EMR and the digital health ecosystem gives us the single biggest opportunity to compress time in healthcare. One of the major issues that has been noticed is time delays kill, time to intervention, time to diagnosis, time to reading lab tests. And this is something which is completely unrecognized. Nobody actually is in a country like India is actually on a large scale quantifying the extent of the problem. A patient has come in, within what time did he have the diagnosis made, within what time was the intervention done? I mean, I know that certain other countries this is much more prevalent, that these are very often protocol driven, but the EMR and the digital health ecosystem enables you to do that. Simple example, you see the images on your phone and you are able to have a diagnosis from a radiologist who's probably seen it at home. You get an alert on the lab test the moment they are ready in the lab. There's no question of a nurse having to call and get the records, or you having to go and search in the patient's EMR. So the point is, compressing time is probably the single biggest reason why every single patient and the entire healthcare community needs to go digital. Unfortunately, this aspect is not emphasized at all, because if we actually are measuring our mortality statistics on a ongoing basis, we will then see what value this can give. And I have seen many cases, even in India, of course, small hospitals, limited settings, where medical records literally help save lives. And if we are not using it for that purpose, we are using it because insurance will pay the claim, or if we are using it for any other limited purpose, we are not really using it to our potential, to the potential that we should be.
Point well made. I think that's a very fundamental part, isn't it? EMR is not just a sort of a sidekick, isn't it? It's almost an integral part of care nowadays. And the way we have adopted it in many of our Western system, at least, even the Middle East, at least I've seen quite a few hospital systems in the Middle East. It is an integral part of the patient flow, the patient care, the administration, and the value that we bring to that. And I'll give a couple of ways we actually come up with that dollar value behind that investment. A good dollar value behind that investment is, for example, measured in something called as the length of stay. I think length of stay is not a big deal in some of the hospitals in India, because they possibly make a business of hotel service as the bed as a hotel, whereas if even Nala's hospital, for example, they want to turn around the patient in what is it like, Nala? It's about 1.2 days or 1.3 days for their bariatric surgery. If they want to turn around such patients within a short time, the amount of administrative work, if it is going to be manual, it's impossible, and it is going to have a lot of error. Its only possibility is through digitalization. The length of stay is a very big measure that we use in the UK, the US, and many economies to validate the benefit of it. But what has happened through the other mode that we now do? So when I was doing the business case for so I developed the digital blueprint for the Kingdom of Saudi Arabia last year, and we looked at the business case from a different angle. So today, if I have 10 patients coming into my ER, the cost of treating them is so high. Whereas out of the 10 patients who land in ER, 5 of them could have been avoided from coming to the ER with just self-care, with just telephone advice, with just having good patient education. And that is how the second value proposition for health, for digitalization comes, particularly when it is public healthcare. In the private healthcare, you want to have more activity to get more fees. But even in the private healthcare, you want to have the most appropriate type of activity with the highest sort of profitability, rather than deal with activity for the sake of activity. So digitalization really helps you to actually, so a lot of the enterprises in the US now have realized that, just running clinics for primary care is not that profitable. But the moment they went into telehealth and having virtual care environment, it has completely changed the picture. Another big area where profitability has become a big driver for digitalization is ICU. Getting ICU experts and intensivists is so difficult these days. And tele-ICU has completely changed the economic drivers in ICU care. Home ICU setups are now feasible just because of digitalization. You have one intensive care expert sitting somewhere, but you've got home ICU nurses taking care of patients at in their home, and you're still able to monitor and give the same quality of care, maybe once they've gone through the intensive phase into the sort of maintenance phase. So there are many sort of use cases that we have, and today, to justify digitalization both on the public and the private sector, it's not a big deal at all, actually. So if for example, we did just about 6 months back, I did a big use case for a hospital chain in Saudi Arabia. And when we studied their ICU and the ability to deliver tele-ICU, they have the world's largest tele-ICU network. They're managing about 750 ICU beds across the chain, with almost 1/4 or 1/5 of the manpower needed. So if you look at how you actually quantify benefits using digitalization, it is either, as you said, time benefit through efficiency, Suman, or the other one is how do you reduce on manpower. Now, reduction on manpower often is thought of as a very politically wrong word. But if you look at the healthcare resource gap in the world today, every country is deficient of the needed number of doctors or nurses or pharmacists. The only way you can bridge that gap, whether it is private or public, is through that digital means. And therefore, to give that value proposition for digitalization, which used to be tough earlier, has now become a little bit more I would say easier because of the evidence that has started mounting. Suman, I was also part of the national program. In fact, I was with Fujitsu, so it's TCS and Fujitsu, we were collaborating, right? And although there was an audit committee at a national level, and we said that about 12 billion pounds were spent by the country didn't get great return on the 12 billion pounds. Today, they are now going back and seeing the benefit of just one particular thing they did. They brought in what we call as the NHS number. The NHS number was the basis of this particular app that I'm saying. And that alone is now giving back a huge return to the country. We have got other things. We've got a spine. We've got something called as a national PACS system, where we are able to exchange images across the whole country. A phenomenally large number of things have happened. Good. I'll just quickly go into Vidya. How much more time I've got?
Take your time. It's fine. No, not a problem.
Oh, okay. I'll just quickly go into what the future looks like before I come to the barriers of adoption. And that's where I will possibly take the questions around the disadvantages and the challenges part of it, where I think, Ravi, you asked that question. I'll come to that towards that. I thought I'll just go into the future. So, but it was a very good discussion to look at so far. Where we are saying is, we got a lot of sort of the horizon looks great. The picture looks good. But is there really value? Is there really money? So should we really go into the future with digitalization, or is this a waste of time? And when we looked at that first question we had, 20 or 30% of the audience felt, no, it's a waste of time. 50% felt it was okay, good to invest in IT. So I just wanted to paint what the future looks like, and I'm not painting what I'm just showing how digital strategies across the world are evolving and what the future looks like and how good or bad it is. Let's see. So see, there are some trends that is happening now, unlike what, because the discussion that I'm seeing in India, from what I'm hearing from my colleagues there, we sort of still in the mindset of the 1990s and to maybe early 2000. For the last 10 years, the digitalization trend has completely changed in terms of what, why we digitalize and what we digitalize has changed. And this is happening at not small levels, but it's happening at national levels. For example, genomics. The reason for genomics, there are many, many reasons. I don't want to go into the benefit of genomics, but the very fact that England, for example, set up its National Genomic Center, today it is answering so many questions, and it is delivering so much of value-based approach to care, that the infrastructure and the investment about 10 years back when we were thinking of genomics, we all questioned it, but the payback is huge now. So things like genomics, things like VR, we've started hearing about the meta, and the meta is becoming more fashionable. It is just starting. So meta is going to be one more sort of revolution, which is possibly going to happen in the next 3 to 5 years. But already we have got enough use cases of metaverse being used in training, metaverse used being in planning for surgery, in patient engagement, in training of people for different skill sets, educating patients about their diseases. So the trends that are being set now for the next 10 to 15 years are completely different from what the trends were. It is no more EMR or HIS system, PACS or laboratory information systems, or even talking about apps. Those are become old world now. The new world is even virtual care and telemedicine. Just because COVID, it sort of had a hype. Not just a hype, it in fact had a great value add, and virtual care is definitely going into a different level now, where we are able to monitor patients remotely and things like that. So these are key trends which are driving that digitalization. So for example, the power of data. The power of data is phenomenal, and I'll give an example. I'm an advisor for an Israeli AI company, and we were developing a solution for them. One of the things in AI is for you to get a lot of data and to be able to use data to validate your use cases, right? And I'm just going to first do a demo of a solution, and then I will show you how that data really made a revenue model for a small hospital. I'm not even talking of any big hospitals with 200 or 300 bedded hospital, but a big revenue model for that. And this is what I'm trying to say, that if you have a digital mindset, you, even in the private sector, you start seeing the value of data. So this was actually an app, and I'm just going to sort of play this. Are you able to see the screen, Vidya?
Yes. Yes.
Dr. Ravi Shankar will be happy with this. This is based on a concept called remote photoplethysmography. So, all of us are used to having our Apple Watch or Fitbit. They're all in contact with the body, right? So they're touching it, and there's a laser light going in, and that's called as contact photoplethysmography. So what this is doing is it's just using my the video camera of my phone, and it's capturing light signals coming out of my face using an AI platform. It's not a gimmick, so don't think I'm doing something. So this is right now there are 6 patents on this, and we have filed for FDA approval, as well as approval in the European context. It's gone for CE certification. And this is a big field. There's a concept called as remote photoplethysmography, where you can actually get to understand what is happening in your blood vessels, your autonomic and nervous system, using light signals that are reflected out. The beauty of this is we managed to not just use any device. So that means I don't need a Fitbit, I don't need to spend money. So that's it. As I was talking to you, we now have my vital signs here. My heart rate, my respiratory rate, it has a stress score, it has an oxygen saturation, and it's able to actually give a trend of that. Let me see if I got, yeah. It is, and it also is something which you can share with your clinician. You can have one per family. And what we have done is we have also brought the blood pressure into this, so it can also record the blood pressure. I'm just going to show how automatically it has created a report, which I can then transmit to my clinician. What we are doing this is we are building this into telemedicine platforms. As and when a video consultation is happening, the device is able to capture your vital signs. Now, I just wanted to show this as an example of digitalization at a personal front. But what I was trying to do here is I was trying to say, how does digitalization turn into revenue models, right? I'll just give an example of that. I needed to test this solution. I needed to get data for this. We needed to test this on different skin colors. And I reached out to a couple of my classmates, and we managed to actually create a use case for this. And within a matter of 3 months, I managed to bring the data required for this from Nepal, from Pondicherry, and also from Delhi. Now, I couldn't have done that without the help of private healthcare. I couldn't have done without the help of my colleagues. They got a revenue return in place. They fostered the development of a digital solution, which has grown. So this is what I meant by all for one and one for many. However small you are, you can now contribute to the global digital health economy, as you would put it. So today they are actually gone to the extent, instead of actually getting the power of data from 1 million patients, there are a lot of new startups which are now going to federated data. That is, I as an individual have power in my data. Just to put it into context, if there are companies which deal with data, right? If you have a full genomic data and a longitudinal health record of an individual, it is worth about $8,000 in the market today. I'm just saying the economic value of a longitudinal health record of a 65-year-old male with, say, diabetes or hypertension and a cardiac failure. Say my mother-in-law, if I had a longitudinal health record of hers, I could possibly value it at $7,000 to $8,000. I'm not telling assumed value. This is the real value. Okay, this is how it is being marketed. Now, what our innovative players done is they are now given the power in the hands of the patients to be able to own their data and actually monetize the data. I'm not trying to make money out of healthcare or any other thing here. I mean, there could be a lot of ethical questions and all that. I'm just coming to the questions that some of our friends asked about their inability to convince their administration on investing in data or health IT systems. And I find that a bit sad, actually. A 200-bedded hospital, and that's very. I made a pitch to Nala's hospital, Medcare hospital, and they didn't buy it about 5 years back. But today they have realized the power of data, and I hope they have put a whole department which is now looking only at data monetization. So there are, and that's just a private healthcare enterprise. So however small you are, having healthcare data makes you powerful. I mean, just putting it in a sort of a cliche, it does add to that. The other thing that is happening from a future trend point of view is these are not just money-making enterprises. These are ultimately impacting patients, impacting their experience, definitely making better outcomes. Today, everyone can have an ECG machine at their house. There are a lot of families here. Atrial fibrillation is, for example, a big issue in UK, and we were spending a lot of money on 24-hour Holter monitoring and all that. There's so many devices which have now come to actually make that so easy to have your own personal ECG. Telemedicine is not anymore just a video consultation. There is so much of haptics. You're able to feel, you're able to hear, you're able to see. We're not able to smell yet, but we'll soon come to that maybe. But there are so many telemedicine devices that have now made virtual care much more different, particularly in emergencies. For example, in KSA, the biggest cause of death in KSA is road traffic accidents after cardiovascular disease. So we have done a big transformation there of how do we provide healthcare right at the roadside, and how do we equip our paramedics so that that the golden hour, we can do maximum possible in the golden hour. We got a big problem in the West, maybe not in the Indian context because we're all having huge families there, is loneliness. And one of the biggest ways of fighting loneliness today is avatars. You would be surprised with 60 years, 5 years, and 75 years old adopting avatars, digital avatars, adopting digital robotic pets. These are not anymore myths. These are not stories. These are real companies which are delivering value and making profit from the delivery of that value. Nothing wrong about that. Genomics has gone into multiple angles and multiple dimensions nowadays. So personalization of medicine has become a reality, and it wouldn't have been possible without the data infrastructure, the connectivity, the amount of R&D that we have put into this, the attitude and the willingness to move towards digitalization of your health structure. I'll just show another sort of at a national level, how are we pushing digitalization? So Saudi Arabia has got a very huge transformation going across its entire healthcare as part of what we call as Vision 2030. I'm just giving this as another example because I was partially I was involved in this. So I was the lead for the National Digital Blueprint and the virtual care strategy there. What does the future patient journey look like? We had to set an aspiration, and as usual, the Middle East guys are crazy, right? Each one competes with each other, and so I brought in the 2030 vision of NHS, and they said, okay, we are already doing that, or a couple of us are doing it. It's not that. See, the problem with healthcare and digitalization is each hospital or each small system might do one part of that, but to have the entire patient journey digitalized, and to do that digitalization across the whole continuum of care, right from primary care, secondary care, tertiary care, across the whole country. That's the important part about digitalization of the future. It's not about just having some toys and having some AI to do something for the rich or the few people who can afford it, or those who have the most high-end gadget only should have access to it. No. It's about reaching this across the whole country, and that's where one of the biggest use cases in KSA for digitalization is what we call as equity of health or equitable health. In India, we talk about equitable health, but hardly we do anything physically or digitally. But I think it's a big challenge, so I cannot. I should take that word back. Actually, sorry. We have different challenges. We have a big country. We have got many constraints. But where there is a will, there is a possibility, is what I'm saying today because of digitalization. If you just went by building more hospitals, if you just went by increasing your bed strength, if you just went on hiring more and more doctors, it has been proven time and time again that that is not the answer for the total solution of a country's healthcare. So this is where we have pitched our ambition in KSA for 2030. What would be the average patient journey, not some patient journey of the sheikh or the 10% of the population. This is what we would want as part of that. So we should all be able to have our digital data. First of all, we should be able to have data on demand. We should be able to have our own personalized health coaching. Health coaching is become such a big element of preventive healthcare, and long-term conditions, chronic diseases, particularly around diabetes, obesity, chronic kidney disease. It's got a much changed environment today because of digitalization on how you handle these patients, how you can be more proactive and put the care out into the community rather than getting them into the hospital every time. So I just wanted to put this picture there. I don't know how clear it is. It's sort of a bit crowded there, but I'll just say, so this is something which we had to do as an aspiration. And we said, well, how does it look like? So this is the average citizen with, say, diabetes. And this is a day in the life of the citizen, the doctor, and the healthcare administrator in January 2030. So we're literally talking of this diabetic patient having his blood glucose being continuously monitored. It is already happening. We've got continuous glucose monitoring in multiple ways, in patches, in corneal lenses. It's all happening in possibly small scale. But by 2030, we think these are going to become very almost universally accessible digital technologies. You will be having a smart fridge. So this fellow's dietary intake and output, or his caloric intake, will come straight away from the smart fridge. He should be able to get his 9-point check or his annual diabetic check in a kiosk. He doesn't have to go to a hospital for that. The kiosk should be AI assisted. We've got diabetic retinopathy screening happening today. We've got skin ulcers screening happening through telemedicine today. His blood test, he didn't have to go to a hospital, wait for 45 minutes to get his blood test. The blood test should come to his house. It didn't come through 2 people carrying a syringe and a thing. It should come with a self-test kit. It should come through a drone, if possible. The test result should be automatically done, and it should be transmitted real time. You don't wait for 24 hours or 3 days for your test result to go to your doctor. When you have the result, it also goes to the doctor. And if it is abnormal, it should have created an alert. All of this, which I'm talking, is actually not out of the world. These are things which are happening in pockets. But what I'm talking of this should become the standard of care. This should become the norm. This should become universally available. This guy's digital pill counter should be able to tell how much more medicine is remaining. It should actually send for a refill. He shouldn't have 3 or 4 days lost without no medicine. He needn't have to go to the pharmacy to buy it. The pharmacy should dispatch it. The doctor should be able to do a virtual ward round. If there is a conference happening, they should be able to contribute together. The patient should be able to speak his experience in that conference. So one thing which is missing today is the patient and public engagement in healthcare. And we feel digitalization is going to change that. The contribution of the public into the healthcare has already changed with the COVID, and their power of contributing to changing how healthcare should deliver should be part of it. So any conference in the future will not just be a doctor's conference, it will be a doctor plus patient, and they will be talking together using a longitudinal medical record. We're talking of possibly an artificial organs being thing. We already have artificial pancreas going on there. We've got robotic telesurgery happening today. So while all of this you can see is connected, the other important part of putting this diagram together was to show the connectivity between every activity. Every action that is happening on one person is actually leading to a connection with the other person and delivering that data. The data is not actually, like you said, Suman, that we are writing it and we are keeping it so that we can go and see the data back. No, the data should become a fallout. It should become sort of automatically a part of the ecosystem, that as you do these things, data gets generated, and the data then drives decision making, planning, cost management, and monetization of that. So much so that we have connected the HR registry of every single doctor in Saudi Arabia, so that we know 1 year before they're going to retire, that how do we start looking at their replacement? What is the skill sets that we are going to lose if that particular doctor is going to be lost? Because that means that capacity from the system is lost. So just wanted to give that sort of bird's eye view of what 2030 looks like for us in Saudi Arabia, and how it is realistically possible. So all our healthcare planning for the country has already started with this aspiration, and we got this 6 or 7 years planning budget to meet that sort of a vision. I will pause here and possibly go to the next question here, and maybe this is something we can open up for voting before we go to the questions. Yeah. So maybe if you all can vote on this, I'm not sold possibly digitalization of healthcare, but do you think digitalization of health is
Sure. Answer to these questions will be very country and terrain specific. No?
No worries. I'm just getting from the audience. Yeah, I
right.
get the point about it. We could go ahead and answer. I'm not taking this and going to publish it. I just want to know the view and whatever audience feels like. That's all. So digitalization of health is not priority for future. We need more hospitals, so spend the money on that. And I'll come to that comment you made, Viswarup. Actually, it does matter. It doesn't matter which countries whether, and I'll come and answer that why. You could possibly say, no, in India we need more hospitals, but that's not really the right answer. Actually, in India, if you did more digitalization, possibly you can reduce on hospitals also. There is only 1 or 2 countries in the world where they've actually, through the process of transformation, started reducing. They're closing down hospitals. So Denmark, Netherlands has done that. Finland is looking at that. These are smaller countries which have managed now through not just digitalization, but through a whole system planning, are actually now closing down hospitals. So the future is not in actually building hospitals, but actually there will be a time when you need to start looking at reducing your beds actually. So the first question was that, and the second question is, healthcare technology should be a mandatory part of undergraduate and postgraduate medical education. I think this is something which close to quite a few. I think we had Dr. Samiran Nandi, Dr. AK. I don't know whether they're still on the call, but these are things which might be close to our teachers. Have all of us responded? Dr. Radhakrishna, any clue on the answers? Maybe I didn't answer. Okay, so we got a balanced response there. We got about 38% who are neutral on the fence. 25% strongly agree that digitalization is the priority for the future. 38% strongly agree. So it's largely around disagree that we need to spend more money on the digitalization. In terms of curriculum, everyone feels definitely almost we need to have that in the curriculum. I'll pause here for some more reflections and questions before I go into the next part of our discussion, which is on barriers to adoption and why adoption matters. Suman, Viswarup, or anyone else?
So if I could just, Shivam, I think the barriers would be probably better off as a discussion with your moderators rather than, because so that will kind of bring a rid up thing and probably will save us some time as well. So
okay.
We have only
can I make just one very quick point here? I think
the floor is yours right now. Go ahead.
Yeah, every one of us who are in this call will now realize that healthcare technology is in many ways seeking to a sizable extent to reduce the patient's dependence on the doctor. Now, this is something which we have to understand. Earlier, a doctor made a diagnosis using his touch, his feel, his hearing, and his senses. Now, the doctor makes the diagnosis using these skills plus a whole lot of investigative modalities. What is healthcare technology doing? It's actually empowering the patient to make an informed decision about both what is his ailment and what are the potential treatment options. So what, for instance, a company like ours, who is currently working on automating the diagnostic algorithm. So basically, you have a set of lab tests that you can have it pushed through the system, and the system will sort of analyze based on the combination of lab data what could be wrong with you. So essentially, when you club this with diagnosis, instant diagnostic kits, with the monitoring equipment, which can also automatically get you the data that you require. The last step is to get all this data processed through the system, through intelligent systems which can think. So effectively, what we are looking at is we are looking at a significantly disruptive change coming in the healthcare ecosystem. And it's probably healthcare is at a tipping point. Maybe 10 years down the line, a lot of this quote unquote OP practice might just disappear, or at least some of it may start to disappear. The second very important part, specialties like radiology, for instance. Diagnostic radiology is getting hit significantly in the next decade with AI-based diagnostic systems. Some of you are already aware. Governments are starting to adopt it in some countries for analyzing large volumes of medical images. So one thing that we all need to realize is we have two options. One, we can say that we will fight this and we will refuse to adopt this, or we can join the party and try to make ourselves more relevant using these digital tools. So I think that choice is what we are faced with, and anyone who believes that this is not going to happen is living in a completely different planet. I can give you an example. There are 17 companies in Bangalore alone working on the metaverse and creation of avatars. 2 of them are focused on healthcare. So there is this entity that is working. Their target is by end 23 to see if they can have a doctor's avatar perform surgery in some other hospital in some other part of the country. So this is not science fiction. This is not 15 years or 20 years or 50 years away. Much of what Dr. Shivam said is already available. So we are not, none of this is something which is totally not there. Some of it is in early stage development, some of it is in prototype stages and so on. But please trust me and trust Dr. Shivam. This is already starting to happen. All of this is already starting to happen, and patients in 10 years time, if not sooner, will be making their own decisions on their diagnosis and treatment, at least for certain primary care conditions.
Thank you, Dr. Suman. I think that's a reality, and it's already happening in the West, and not just the West. Middle East is. I'm surprised with. In fact, Middle East is overtaking in fact, if I should be a little bit more blunt, US possibly is really behind in this in a big way. Europe and Middle East actually have taken the front end of this, largely driven actually by the patient engagement. The population themselves are very digitally active now in these countries and in these sort of geographies. And not just this, I actually had some slides and I had to remove. Africa is now the country with the largest adoption of mobile health. The biggest transformation in the African healthcare system has happened because every single mobile health in that country is now a potential health tool. And the WHO is now spending huge amount of time and money in the African subcontinent to learn the lessons from there and take it to the West. So mobile health by itself, I mean, mobile health was the era from last 10 years, but the way Africa adopted it is phenomenal. So it is not about cost. It's not about socioeconomic status of the country. It is about the willingness, the political, as well as the attitude of the public is critical in this. And one important thing which drives this is the healthcare professionals. So the adoption is on two fronts. You've got the public adopting it, and public will adopt it wherever there is, everyone is going to adopt it when there is value in it. But the public adoption has become a big escalation in that with the pandemic. And now everyone is asking for digital health and digitalization of tools. We got 100% penetration of a particular app in KSA when COVID came. And on back of that, because there was 100% adoption of that app, we built about 20 users. It was for COVID vaccine and making COVID vaccine mandatory. But we took that as an opportunity because 100% of the people were looking at an app for COVID. We took that for at least 20 other use cases, right from diabetes education to screening for diabetes. And it has become a success there. So the ingredients for digital success is already there. Technology is there, knowledge is there, cost is coming down, engagement is going on. One big resistant, though, is actually clinicians. Adoption of technology.
If we could just pause there and bring in the physician willing to adopt technology aspect in India from Vishwarupal. Over to you, Pal.
Oh yeah. Okay. Am I audible?
Yes.
Yes.
Yeah. So I think as of now, India is very heterogeneous. Sumant is far more experienced than me. So it is impossible to bring entire India under one umbrella. Even the public healthcare system cannot be under one umbrella. Health is a state matter kind of thing. Those kind of things come up. And in private healthcare, it is even more heterogeneous. I mean, a 50-bed hospital also functions, and next door a 300-bed corporate hospital functions. But few things are common among all. One is, as far as for me, the most important obstacle has been the clinicians and blue chip clinicians more, because one thing I find is the eagerness with which a senior clinician adapts to a technology of his or her subject, uh, whether it is surgery or anything, is phenomenal, that eagerness. And it is matched equally by stubbornness in adapting to any kind of digitization. And incidentally, this is not one state specific, it is across the board. Right now, I mean, as Sumant said, whether 10 years from now patients will diagnose themselves all the basic conditions, truly speaking, I am not interested in that at the moment. At the moment, to me, far more priority is, if today, even today in 2022, if in my hospital my 5 residents are writing notes in 5 different manners, the way each individual is writing, that's one. And my patients are still standing in the queue to register in India today, India like country at 2022. I think we are far too basic things to we have to sort out. And as far as the I mean, I focused on MSME hospitals because, truly speaking, I have no intention to deal with an Apollo or a Fortis as a business partner. But MSME hospitals are below the radar, and they do huge volume of business. Okay, even in Chennai, if I give you the data, because big ones are on above the level, they are visible and audible. Now, in all the smaller hospitals, I found, as I approached them, as I gave them the mathematical equation, because one resistance was this, they can't afford to have a full-fledged IT department, their server and all. So when now across the board in entire IT segment, SaaS supported businesses are doing extremely well because it's a recurring revenue. So to sustain a business, that is, scalability and sustainability are very important. Only then we can evolve. However, I definitely found the in terms of on the ground penetration, we are finding it a lot easier outside India than within India. Uh, and for that, I think we are neither Africa or nor UK. We are somewhere in between, and that too in a very divergent manner. So that is the area. And as far as utilizing the data for further qualitative benefits, which will turn into revenue and also better clinical decision making later, that at the moment is a bit of dream for me if I have to go through this. Thank you.
I think a very well made point.
I don't know, Sumant has been in the market, I mean in the forefront, he has been pitching products. Maybe he can give different inputs.
I can give, go ahead, Sumant.
Yeah, so basically, yes, I think in India, as as I said in the previous meeting as well, the regulatory framework will have to be tightened, and there has to be the legal requirement to mandate this. So until that happens, we can have 1,000 sessions or discussions on this. People can be well intentioned and so on. But if the government is not going to insist on an electronic medical record or digital health in any way, it's not going to happen. And let's be very honest about that part. So somewhere, those of us who have some kind of contacts within the government establishment need to get them to pass some kind of a law mandating it within a period of 5 to 10 years. And what would happen is you will see that one step will actually have multiple spin-offs in terms of improving the quality of care delivered, because it becomes easier to measure what is being actually delivered. Right now, nobody knows. I mean, each hospital is its own empire, and at scale, we do not have qualitative indices of healthcare delivery in any part of the country. Forget government, even in the private sector, there are extremely limited number of hospitals which are even performing basic qualitative assessment of their healthcare delivery measures. Simple things like infection rates, mortality rates. I mean, mortality rate condition wise, you will be surprised to know that the vast majority of hospitals in India simply don't have this data reviewed on an ongoing basis. I'm talking about government and private. So this is where we are. So we have to wake up to the kind of neglect that has happened in this sector for so many years, and it has got by because there is this most unregulated industry. A tea shop is more regulated than a clinic in many parts. Clinical Establishment Act was brought in. Most of the states have not signed up. The few states that signed up are not enforcing it. So there is a problem, and that problem has to be solved. It is the government eventually which has to take the lead in this, and it is our responsibility to lobby as hard as possible to get the government to do all of this.
Thank you.
Probably, as I am somewhere connected to the Quality Council of India, where we are trying to lobby that any accreditation, this can be an integral part, because passing a law through Parliament is a long process, whereas QCI functions in a lot more autonomous manner, and since this is qualitative, probably that will be compelling people to, because there has to be a compulsion. Incidentally, I must admit, even though nearly 30 years I've spent in private healthcare, and it is a transaction, so I have no hesitation to call it a business. Hence, my patient is also my customer, but my care may be patient-centric, but it is not customer-centric at all in terms of convenience to the customer. And either law or accreditation bodies or the patient lobby, I can share this with Shivam, because I am a firm believer that intuitive intelligence in India is so high. It is wrong to believe that a villager will not be able to adapt to digital health. If the Ola Uber drivers in the hinterland of India, without much knowledge of English, can navigate through GPS, intuitive intelligence. That's how e-commerce has spread into. So I think the customer is very eager. We are avoiding or ducking due to convenience at the moment.
That is where the market forces will push you guys. You're all being protected so far with that so-called physician-centric model of healthcare or hospital-centric model of healthcare, and you've been protected so far, and you're able to manage it so far. It is not going to hold on. The market forces will drive it. I think, for example, even cost. HIS used to be very expensive. Now, as you said, the SaaS models, the cloud-based models have made it so cheap. There is no excuse for any private hospital to say, look, we can't invest on HIS system because they're expensive. You can just do it you could just spend 2% or 3% of your outpatient billing charge towards actually having your. So you may even put it on the customer actually, and the customer will say, please put it on my bill, and I would as well have my digital record on my mobile phone rather than not have any knowledge of what is happening to me. So I mean, there have been sort of excuses sometimes, and I hear what Suman is talking about regulation, but I firmly believe in market forces versus regulation. So 2 or 3 things which you said, Biswarup, like accreditation. Nala is on the call. He can possibly say they file accreditation, JCIA, this and that, literally left and right, and they have managed to meet the requirements in 2 to 3 days if required, because of the digitalization of their data. Absolutely. And to be able to demonstrate the evidence. Similarly, medical litigation. If today, without an electronic medical record or without having electronic systems, to be standing in front of the court and managing to fight medico-legal cases, it's actually a pity, rather. And when you have these, and I heard someone said, yes, if electronic medical records will actually expose you rather than hide you. You are not able to delete data from it. These are sort of very archaic sort of attitudes within the clinical profession. And that has to change. And that's, I can definitely vouch for it. That has changed considerably, at least in the West. It is changing in the Middle East. I've been to 2 or 3 African countries. It is changing there. So if it is not changing in India, I doubt whether it is because of literacy or regulation. I don't know what's the, I mean, I'm not a diagnostician there, but I'm just saying that, look, there are other barriers which we need to overcome, and we can't overcome purely by regulation also. But regulation is definitely a huge area. Regulation actually should not be to mandate, it should be to facilitate things like privacy, data security, data breach, data sharing agreements, when can you sell data, when you cannot sell data, controlling the big pharma, the big companies exploiting data. That's where possibly regulation should be, rather than saying, look, guys, you have to use it. But regulation, yes, particularly from claims, for example, if you are going to be in the insurance driven environment, manual claims, and the amount of time spent on 30%, 40% claims being rejected, the amount of account receivables. There are some, because I know this because I'm dealing with a HIS company from Bangalore, and they talk about their claims receivable, the account receivables, and the balance because of paper-based claims. There are at least 6 to 8 months behind in getting their money. The cash flow to the hospital is literally delayed because they have submitted paper claims. So there are quite a lot of sort of reasons on this side and that side. But by and large, I think what I talk about adoption is, if you are not clear about your need, why you need that, and you're not going to actually get into that. That's the first thing. The second is know your customer. And that's a very important point you made about treating your patient as a customer. The moment you start treating them as your customer, rather than just recipient of some injection or procedure, your attitude changes. And your ability to serve them through digital means becomes completely different. And it's not huge cost, it's not huge effort, and you can do one-to-many, and that's the advantage. It's not one-to-one. What you do for one person, you can actually replicate it quickly and actually have that customer experience multiplied many times. The other key thing is you should know your place in the digital ecosystem. Are you a small hospital? Are you a single doctor? Are you a patient and you want to actually take the digital health of your condition into your hand? You need to know where you are within that digital ecosystem. But agreed, there have been some barriers, one interesting barrier which actually is happening in the West is actually the other way around. They are now thinking about the safety of digital health, because digital health has suddenly spawned, right? And digital health is actually an intervention. We don't do randomized control trials to release a digital app, whereas we wait for 10, 15 years on a randomized control trial of a procedure or a drug. And there is certain concerns there, actually. And in fact, that has become the negative adoption barrier within the Western environment, particularly data privacy concern versus and the safety of it. There is so much happening in the news. I just took last 24 hours from my iPhone to say, how much noise is there in the system. So there's also a lot of noise in the system that is possibly giving both positive and negative signals to the customers, and both to doctors and patients and to the thing. So you got things like, AI, is it really going in the right direction? Is it actually going to create complications? There was a news on MIT, Harvard saying that, AI can recognize race from an X-rays. Now, the ability to recognize race from X-rays is such a big problem in the UK that the Western country. This can by itself derail an IT program. Racial equality is not being met, for example. But that's a problem that has come. We call this as unintended consequences of digitalization. We never intended for AI in radiology to be able to detect race. It wanted to detect tuberculosis or cancer or for lung cancer screening. Unfortunately, that algorithm now also detects race. how do I deal with these sort of unintended consequences? So these are also adding, unlike India, where you're dealing with more sort of basic problems of adoption. In the West, we are dealing with certain other serious problems of adoption also. So I think we need to balance that out and see how we somehow get a middle path. At the end of the day, without adoption of healthcare, that can be a challenge. I just wanted to put this last bit of thing for some statistics here. In 2021, there was a survey done in US, and I don't reckon US as the best place for digital adoption. While people felt that it definitely comes with benefit, they adopted it to some extent. What they felt was it also had a lot of negative. So all that points that you guys were making, there is that we are still in that sort of transitional phase of adoption of technology. While people used it, they also said, it was not efficient, it was not safe, staff were rude. Sometimes digital health was more expensive than actually face-to-face health. But the bottom line, what is, at least in 2021, 2022, where we are, and this is what possibly our teachers and the older people in the audience might possibly be saying, hey, this looks better, is that we still are not at the place of replacing the art and the heart of medicine with technology. We are doing a lot. So although my whole talk was to glorify technology, at the end of the day, the doctor is the doctor, and the art and the heart of medicine is still yet to be won. The experience that you get through technology is not yet at that point. So we have to be humble. We need to accept that. And therefore, there's a lot more for the digital industry to do to enhance that experience from what it is today to much more better. I'll sort of stop my talk there, and I hope I've sort of kindled some debate and given some insights. Vidya, Dr. Radhakrishna, to the Suman, Biswaru, I'll hand it over to you, and thank you for that opportunity.
But before others come in, I just want to share one more experience. I think no matter how eager I was, for at least a decade, I have been put off by the HISS I used to see in my hospitals where I work. And the single most pathology was, it was made by engineers for consumers who were not interested in the product. So buyer was poor, the provider also provided poor quality. So then it started in my mind that the product doesn't talk to me. There is no interactive plane, because they were made by people who had no connect to the medical practice. So I think it is very, my suggestion or urge to colleagues is, see, this is something, it's not going to be preventable. It is 1 year or 5 years. So if you can't prevent something, better be in a position to control it. And like, for example, for the company where I am involved, I am the content provider. I have no intention to become a code writer today or an IT professional. I have my better expertise in somewhere else. But the way I create the content, or I take suggestions, when I'm doing the oncology module, I actually sat with a surgical oncologist. I actually sat with a medical oncologist of enough experience, took their input and created those modules. And then I found they are much more liked and user friendly for the users. Thank you. I'm just sharing certain on the ground experience.
That's a very valuable point, Biswarup. And one of the things we have done in UK and even in KSA, we have actually made it mandatory, legal policy that all solution design, any technology design, should actually have a patient forum and a patient engagement part of it, and doctors engagement. So there is any design, any solution that comes to the market in the UK today goes through a ratification through a patient group and a clinician group before it even hits the road. So these are things which are, again, part of regulatory exercise. So we have made it mandatory now. We have made it regulatory, and by law, it should actually have that. And not only that, we also brought in a regulation around clinical safety, which, because these are devices now. These are health IT is actually impacting health safety. And therefore, we also have to go through a clinical safety approval for digitalization. So I think you're very right in the level of engagement. But what one point I want to make on the back of what you said, Biswaroop, is the sort of mistake is to some extent on the healthcare faculty. We have not involved ourselves to the level that this industry needs. The engagement of doctors and clinicians in digitalizing healthcare is pathetic compared to the other fields. If you take other fields, you take banking, or you take mining, or you take the amount of time and money the subject matter experts have put into their own industry is phenomenal. We somehow, I don't know why, you know, it's either fear. So a lot of people have asked me, why did you go into IT, you know? Reasons apart, what I tell them now is, look guys, you can actually make decent money at the same time, have satisfaction if you want to do this. And it's become sort of my mission to actually mentor as many people as possible to get into digital health as much as possible. Any other reflection?
So, Shivam, would you like to stop sharing your screen so that we can see all the parts?
Right. Vidya, can I just put in a small?
Yeah, go right ahead.
Having said, I've been listening to him for all this time. I think he talks too lot. And most of the slides were crowded as well. As like digital technology. I think, you know, part of it is true, part of it is not true. In chronic, digital health system can be very useful in chronic healthcare. And that's what Suman and Biswaroop were telling. In acute healthcare and in acute medicine, it can be little tricky. And he himself said, shows his slides, in primary healthcare, they could adopt it to 100%. When it comes to secondary healthcare and bigger places, it's difficult. But there should be a motivation to go ahead because it helps a lot in so many other ways, which should be taken as a positive. Now, coming to say why in India we are not able to do this, I'll tell you a simple example. I wanted a police clearance for a particular purpose. And this time I found out I could get a police clearance certificate from a hometown in Coimbatore police station in 24 hours. And then I found out the SI told me it's all digitalized now. We just go on the computer, we go put on your passport number, and then immediately it will say whether in India do you have a criminal record or not. If the police people could do this and come to this level, and many of the other systems and business industries are using it, it is sheer lack of willingness. And I think the government has to put in a lot of effort. Similarly, the private industry has to foot in the bill. It is going to be initially costly, but over a period of time, it's a long-term investment. And in the long term, you are going to reap the benefits, and it will definitely add more quality to the patient and safetiness. But having said safetiness, we see most of the wrong side surgery happening in US and UK, even after all this healthcare and digitalization done. So still a touch of human hand is very important, and human mind is all that is very important in medicine that cannot be replaced at all. And telling about manpower is very important behind this technology. In fact, UK is a place which has hired maximum nurses from India. Now, how will a nurse from India go all the way to UK and get trained up to get into the digital health system? It needs a lot of effort. So manpower behind digitalization and the requirement of people and the hardware, both of them are going to be cost effective and needs training. But end of the day, if you put it for 10-year time from now, definitely you will reap a lot of benefit. It's a long-term investment. That's all I can say. Thank you.
Dr. AK, you've been patiently with us despite it being close to 2 hours. What's your response to Shivam?
Thank you, Vidya. I was hoping that you won't ask me to speak, but since you have asked me, I'll say a few words. By the way, Subbu, I still like to operate one patient at a time. It's not a mass chess game where you play 20 at the same time and hope that you can win at least 75% of the games. Okay. But anyway, you've gone into a different world. Now, and he also said that the older members will not agree with what he says. I am probably the oldest member. So let me start the ball rolling. The thing is, in a nation where access, transport, and affordability is the issue to healthcare, how much are we justified in saying it has to come and the government has to pay for it? Who will pay for this? And what will be the utility in the immediate context? That is what we have to see. And I do not see justification for proceeding on massive expense in this direction at the current point of time when we cannot ensure even access. Whether it is Subbu spoke of the shape of things to come, as H.G. Wells put it, it is, I agree that probably it is the shape of things to come. Is it likely? It's very likely. Is it inevitable in the future, near future, distant future? Probably yes. Is it undesirably desirable at the current point of time? I certainly think it is not. So I have issues with the speed with which we are progressing, and Subbu himself has mentioned that the issues with speed and the pressure for digitization has provoked in the United Kingdom is likely to happen here with a lot more damage across the board. And therefore, it has a place where the preventive, promotive aspects come, where you need statistics, where policy has to be made. We need a lot of digital records. But if you have only digital records, and Patta will bear witness to our encounter in the recent past, it takes away a lot of time focusing on the digital records and very little time on the patient. And therefore, that interface between patient and the physician is almost completely lost. And my son, who is now in the US, says they hardly spend time making eye-to-eye contact or talking to the patient because they have to read everything on the screen and enter what the information that they gather on the screen. And then therefore, at the end, if the patient is lucky, if they spend 2 minutes in answering some questions. Such a situation, I don't think will fortunately come to India for some time to come. And as a believer in interaction, I feel that digitization has its place, but has to wait its time. After all, 90% of the conflict, and Suman is a public figure, he knows, between the public and the doctors is because of lack of communication. It is not because of bad medicine, it is not because of bad treatment, it is because of bad communication. And whatever little communication is there is likely to be diminished further by this progress towards rushing for digitization without seeing whether we are mentally, financially, physically, and intellectually prepared for digitization in this country. And I have been in healthcare for nearly 60 years now, and that is my very personal opinion, therefore not to be taken as an example of everybody, even those belonging to my generation. Having said that, last word, Vidya, last word. I never have the last word with an anesthetist except on the Zoom link, and therefore I can tell the last word to Vidya now. Otherwise, they always have the last word from across the screen when I am operating. The last word, I've forgotten the last word, I'll tell you when I think of it. Therefore, Subbu, I think there's a place for advocating, but advocacy should not be the aim. Advocacy should be the means to the end and not the end by itself. And I know that we have interacted together, we have worked together for 8 years. You'll understand the way I think, and that is my personal opinion.
Thank you, sir. Very valuable opinion.
So the reason I interrupted you, sir, was to just get Suman to respond to the things that you were saying before we lost the thread.
The problem is, if you interrupt me, I lose the thread.
So, sir, see, one of the major advantages is actually to see how access, affordability, and quality can be improved. The whole purpose of digitization, the journey of digitization, the purpose is only to improve these three things. So, for instance, through telemedicine, for instance, is helping to improve access. And, whether it is through remote diagnostics or a whole lot of other solutions are aimed towards improving affordability also, because eventually what you charge for it is dependent on what the basic costs of such systems are. And actually, from my experience in the Indian context, the biggest barrier has not been, cost was a big barrier till about 5-6 years ago. But in the last 4-5 years, we are talking of investments of a few thousands on a monthly basis for a hospital to equip itself with a medical record. We are not even talking in terms of lakhs. So I would sort of be more concerned about the fact that there are other reasons why we are not adopting. And the very important part is, again, we are getting into this scene about the electronic medical record per se, But today, it has become a centerpiece around which a whole lot of medical devices operate, sensors operate. So a whole lot of other ways of capturing information from the patient, which we would otherwise not have had. So for instance, monitoring patients at home. So today, I can tell you, till recently, I had a relative who was being monitored by his children from the US, who had a camera. There was a nurse. There was a full-fledged ICU setup, mini ICU setup, short of a ventilator in the house. So things like that were being facilitated by digital healthcare, and the children were able to monitor their father's day-to-day health in a much better way than they would have been able to do by a phone call with the nurse. So little things. So we don't have to look really at the cost. Costs are not the reason why digital healthcare is not happening in India. Lack of revenue-making opportunities for the hospitals, yes, that may be a cause. Telemedicine is not as paying as a face-to-face consultation. That is why, our team, we started the first healthcare telemedicine portal in India way back in 2000. And we found that until COVID, there was hardly any traction for telemedicine. Mostly it was being done by government and a few universities. So that has been the challenge. The challenge is not so much money as lack of revenue-making opportunities. And in fact, in some cases, it actually reduces the revenue to the hospital. And importantly, why should I do it? That's another big challenge. What's in it for me?
So, if I can interrupt Shivam and Sumant, like you said, most doctors get stuck on that part of the EMR doing entries during a consultation. I mean, that is only 1 zillionth part probably of what you're talking about. So to address that, I'm sure there will be systems can be put in place where I still talk normally to the patient, but whatever we are talking will get the audio will get captured, and then it can probably automatically get entered. I'm sure we'll reach that level also, so that we don't need to take our eyes off the patient and only look. And the other thing that Dr. Eke was saying, I mean, there will be a response in Tamil. He said, and the doctor and onnume kekala, because everything was already on the record, so I didn't ask. So that is possible. But that is why the point that Shivam talked about at the end, that it should become part of the curriculum. So there are ways to do that. As I'm looking, you say, oh, I see that you've been diabetic. So how long was it? And then it's just a side question. It's already there, but you can ask, or, something. We have to learn to bridge and retain the human touch as well as the electronic touch. So I can see Shyam's camera is on now. So Shyam, we'd like to
add one point, Vidya, if you don't mind.
Yes, sir. Yes, sir. Absolutely.
Or if I can wait for my turn after.
No. Go ahead, sir, please.
Suman said something. The cost is not much. The cost is not much, Suman, but even little cost. See, I worked in Jipmer for 30 years. And 8,000 patients a day, 4,000 of them will be sleeping on the road outside before they come and stand in the queue in the OPD at 12 at midnight, so that they can be seen on that day. They tried to raise revenue for digitization by charging 10 rupees for the OPD slip. And there was a huge agitation, and all the politicians that you could think of, and probably every politician in the country was there outside in the gates of Jipmer, agitating and saying. They tried to charge for a few drugs which they could not afford to give free, and out of the 8,000, 7,000 are those who cannot really afford. All right, they come there because there is free treatment. They come long distances. They come for follow-up in long distances. and leave corporate medicine. Corporate medicine is a different world altogether. There are still government hospitals. You go to General Hospital Madras, you know very well about that, or Stanley Medical College, or any of the public hospitals. Where is the money going to come from? And even if you digitize, who is going to be there to enter the data? Because they're always functioning with just barely sufficient staff. You see? And there is no expertise available. And the Wi-Fi is so poor, even if you have the data there, it cannot be accessed when it needs to be accessed. You see, these are issues which face us every day in the OPD. Throughout the 30 years I worked there, throughout the 10 years I worked at All India Institute, this is the fact of life. You cannot say what happens in Apollo will happen at Jipmer. I'm sorry to disagree with you because I have a lot of respect for what you say on TV, but this is one subject where I probably know a little more, having worked in public sector for 50 years.
Yes, sir. My kind submission only is that things have improved a lot in the last 5 years, sir, in terms of connectivity, in terms of infrastructure. Because sir, for your information, we also were associated with some work in Jipmer long back, and we faced very, very significant challenges, and you know, we were able to achieve only 5% of what we actually set out to achieve. But that was about 15 years ago. But I agree entirely with you. But for Tamil Nadu, sir, Tamil Nadu government has computers placed in almost all government hospitals across the state. OPDs in at least more than half the hospitals have adequate number of computers. The investment has already been made, sir. Unfortunately, you're absolutely right. Doctors have not been willing to enter the data. So while the reporting system is working beautifully across the state, that was done by us when I was in TCS. We were the team that put the entire project together. And even now, there are at least about 25 to 30 government hospitals where the electronic medical record is also being used. So there is a possibility of doing this. But again, I agree entirely with you. In a public sector kind of a setup, it's a lot more challenging than in a corporate hospital.
Can I just add a reflection on this discussion, because I think we get what I'm hearing is that the whole mindset in India seems to revolve around HIS and EMR as the digitization solution. Unfortunately, that is the wrong thing to think of. Today, your mobile phone is a better digital tool than the computer sitting in your outpatient. The mobile phone being used by the patient is much more powerful than the mobile phone being used by the doctor. So the way we are looking at this so-called data entry, data capture, there is a huge change that has happened, sir. And you know, I do understand the US has always had this challenge. And that's why I said I will not like to take US as a good example for digital adoption, in fact. And that's why they brought in all these things like meaningful use and things like that. And there's always been the challenge. But if you go to the same US, if you go to the same Cleveland Clinic, or if you go to the Mayo Clinic in the private, so-called more privatized environment, you find the way of data capture is completely different. And we don't need to literally spend that much time in data capture. But it is still a challenge. No doubt, Dr. Natarajan, that definitely that is a very valid point. But these are barriers that can be overcome. And the only way to overcome that barrier is to see the good of it and the benefit of it. The same Jipmer, if we had the digital data of that, if Jipmer had been digitized in 2000, I'm sure it is much more better than the John Hopkins of the world today. You would have the best research from there. You would have the best IP that would have been created, and that IP would have paid for that HIS system. Why we didn't create IP from Jipmer when IP was being created in AIMS? We have the best material there. The intellectual property we had there couldn't be capitalized because of that lack of the digital data. Who was going to go and sit in that MRD and get that data for us to file for a patent, for example? So I understand the challenges, but I think there is a way out if we balance it And I somehow feel this challenge about revenue generation versus cost of IT. That was 20 years back. In the last 5 to 10 years, at least, with all the big companies, with all the governments going behind the need for healthcare innovation and intellectual property and innovation, every single hospital, even with the solution that I showed today, I needed 500 patients where we needed to get a video of their face for 5 minutes when they were connected to a BP apparatus, a BP monitor, that's all. But that created enough revenue for that small hospital to actually do that, right? Now, you can imagine I'm talking of nothing but a data called blood pressure. Imagine the data that we should be getting from our cath lab in Jipmer or our endoscopy lab in Jipmer. That has got a huge value, doctor, today. We never realized that potential of data and its value because we don't have it. The moment you have it, then you will see that it can repay quite a lot of the cost also. But no last words here. I completely take the balance of situation. And as Biswarup said, India is different. The different countries are different in the way they adopt it. But I feel while Indians are going and I am taking a HIS system from Bangalore and deploying it in Saudi Arabia at a cost which is 75% of the cost in India. Frankly, it is. They are deploying it in Hyderabad in a private chain of hospital. The cost I am procuring it in Saudi Arabia is at 75% of the cost that they are selling it in India. So if Saudi Arabia is able to procure it, the scale that you can procure in India is phenomenal.
Shyam, we'd like to hear from you.
Sure. This has been a really fascinating talk and discussion. So I'm going to come at this from a slightly different angle by looking at some other sphere. If you look at automation of driving in cars, the way it has progressed is in steps, right? So you have, I don't think anyone now drives a car with a manual clutch anymore, right? So that was kind of your first step in automation. You remove the clutch. And then you went on to have all these things which would tell you that there's another car nearby and things like that. Then it went on to like, it'll automatically apply the brakes when it thinks that you're going to hit somebody. And then it's gone to a step where you steer, but you don't have to control the speed and the brakes. And then eventually you got the Teslas which just drive by themselves. So the parallel from there is that you want to go stepwise in any kind of automation. So at the end of the day, digitization, the goal of digitization is to automate. And the question is, why do you want to automate? You want to automate essentially because you get better outcomes and safety. So not all automation necessarily leads to better outcomes and safety. So you want to identify the areas where you think automation will lead to safety and outcomes and kind of tackle that first. So from that perspective, really digitization and automation is far more important for preventive care. Because if you look at where you really want to improve outcomes, it's not the expert cardiac surgeon or the expert gastroenterologist. Those guys, it's going to take us 50 years to beat them with machines. You don't need to beat them. But what we have miserably failed in is controlling diabetes mellitus, hypertension, and dyslipidemia, and the complications which arise out of them, right? So that's where I think the ability to collect data, where you really don't have a data entry problem because there are many methods to collect this data. And a lot of this care is going to reside outside your hospital systems, right? The reason hospital systems are not good at treating these diseases is essentially you have people come in, patients come in once a year, you get a spot measurement, you make some decision and you move on. But what we really need is far more continuous way of measuring your blood pressure and your sugar levels profile, and giving feedback, whether it's in terms of drugs or physical activity or diet, right? It's a combination of all this three that you have to control. I mean, that's where I think the sweet spot is, because one, it doesn't have this feeling that you're going to put doctors out of work. In fact, a big chunk of that work, doctors really don't want to do that, right? You don't want to keep calling up the patient every day and trying to get the blood pressure measurement, for example, because that's what you need to do a good job of knowing where they are. And also, kind of the medical treatment of this is only a small part of this, right? It's at this day, basically what we have is, I guess, really diet and lifestyle. Maybe you can use the genomics to make it more precise or whatever it is. And that is something where I think physicians can help a lot. Right now, it's all driven by Silicon Valley. And they've been doing this for 20 years. And they've not gotten anywhere because they don't look at it as a health problem at all. They look at it as a technology problem. So I think the ability to collect the data, and it's a small amount of data really that you're measuring, and the ability to use AI to kind of give the feedback and improve the outcomes and show that using like clinical research methods that outcomes improve, I think will be really, really critical. And it also shifts the economic model. Hospitals don't care about preventive care. The biggest problem in the US is that I don't get paid to do preventive care. The hospitals will all collapse if we did preventive care very well. They all survive because of the complications of these three major conditions, right? So there is a disincentive for them to actually fix this problem. But who cares? The guys who care are the insurers. The insurers definitely want to cut down the complications and the cost, and they want preventive care. So you go to them and suddenly you realize that they are willing to fund all these things, and they don't care whether they're funding the clinical side or whether they're funding the technology side or funding someone else, because all they care is they're paying this cost of medical care out and the premiums are not sufficient and they keep increasing the premiums. And they just want to be able to have better outcomes and costs. So I think that's where the sweet spot is. And then in terms of coming into, I guess, hospital-based care, you want to have a stepwise approach. You want to look at areas where things can improve by having digitization and automation. And those are typically areas that humans are bad at. Monitoring is an area where we're really bad at, right? So here we have a big group which just does intraoperative neuromonitoring for complex surgeries. We look back, they're missing more than half the things because 8 hours we're watching the EEG continuously and trying to pick things up. Humans are really poor at that kind of stuff. So monitoring is an area where you can bring this in. You don't really have a data entry problem because all the things that you're using for monitoring, whether it's heart rate during anesthesia or EEG, intraoperative monitoring, they're all coming out of the machines, right? You can just feed them in and put the AI on top of it and let it do its job. Similarly, for preventive care, hypertension, diabetes, mellitus, and things like that, you have all these devices which patients can use. And the data just comes out and it's already in there. So you can do a lot with just the EEG signals, with just the heart rate trace, with just the blood pressure trace. And I think that's where the sweet spot is, to show that technology can help and outcomes can improve. And then you start pushing into other areas. I guess the specialty which is probably, or the specialties which are probably most affected are the imaging specialties. The radiologists are, of course, that's all they do. So they're 100% imaging, but you have also cardiologists who are some level of imaging, ophthalmologists, dermatologists. That's where looks like at this point in time, you don't have a data entry problem. The machines generate these images, and you don't have a problem processing these images and applying AI. the current AI technology is supposed to be exceptionally good for images, exceptionally poor for EHR data of other types. So if you look at that sweet spot where data is coming in automatically and you've got AI which is working really well, that's where, again, I think the push will come because you'll be able to show that it works really well and you can automate. And in fact, if you look at the FDA certified AI for images, what I've seen is none of them do any better than humans. So one example is there's a automated way of reading CT scans to detect strokes. The AI, it's top-notch AI, right? The imaging AI is supposed to be top-notch. It's no better than a regular radiologist. But the reason it's being used is it cuts down the time. So you do the CT scan, when the patient comes into the emergency department, it's read by the AI and it automatically pages the stroke team in. And they're able to save somewhere around 2 hours time compared to the manual process where the radiologist reads it and then says, hey, we need to call the stroke team. So a lot of this is going to be really workflow automation rather than diagnostic, trying to diagnostic accuracy. As long as you hit current diagnostic accuracies that you're doing, that's good enough sometimes to deploy these automation, digital technologies, because you save on essentially time. The other thing you save on is consistency, because the AI will perform consistently throughout. So you don't have this heterogeneous problem of different hospitals having different ability to deliver stroke care, right? You basically got the system which runs and it's guaranteed that it's going to page the stroke team within an hour because of the way it is set up. So that's again where the sweet spot is, really not really on the diagnostic side. So I would say it's mostly on monitoring side, also monitoring of data which is outside the healthcare system, like home monitoring and home monitoring, not just for the disabled, but home monitoring for just like hypertension, diabetes, and say dyslipidemia. So I think it's the judicious use. What's currently missing though at this point is no one has really shown that outcomes have changed or the quality has improved. Maybe it's too early to show that, or maybe people are just working on the wrong things. You try to take an expert cardiac surgeon and you try to show that a robot is better than him, good luck. That's going to take you hundreds of years. And the reason is we as physicians are specifically trained for 8, 10, 15 years to do that. It's going to be very hard to beat that. And the question is, why do you want to beat them at this point? You got a lot of low-hanging fruit, right? You want to improve essentially these primary care problems first. So to some extent, what we really want, I guess, is even though we're all specialists, and so we have this bias, which is we only look at complex medical situations, and we're thinking of how the digitization and AI will help us. We really need to go back to our roots, which is preventive and social medicine, and see how we can help with that, and how we can, as physicians, get involved with the technologists and not, don't leave this to the technologists. This is something when I give my lectures to medical students year 1 and year 2, they get a little bit of AI. That's what I tell them, is that your job is not to learn machine learning and AI and develop all these models. Your job is to get involved and make sure that the priorities are right and kind of figure out where is it that you want these things to work. And so I think it's critical that way that we need some level of teaching of this to the medical students, not because they're going to become developers of technology, but they are the ones who can really focus the technology in the right areas. You divorce the physicians and the patients from the technology, then you can end up with really bad results at the end of the day. And I'll give you a particular example from the US. The current EMR technology in the US is completely divorced from clinical use. And the reason is because the clinicians are not in the loop. The people who make decisions and pay for the EMR are essentially the bean counters. So all they care about is capture of data for billing. And so all the EMRs, the big EMRs from the US, Epic and Cerner, they're very, very good for billing. And they're very, very good at driving physicians crazy to do the data entry for billing purposes. In fact, the data in the US EMRs is so bad that clinicians want AI to extract relevant clinical information out of it to help them. So the ways handoffs occur in the US, say from Friday to the weekend team, okay? Nobody looks at the EMR. They still have a piece of paper and they have the summary, and that's how the handoff occurs from human to human, because the EMR essentially is of no clinical use at this point. So you have to be careful that the users are involved at every stage. And the funny thing with the US is that they got it right the first time around. The first EMR system was actually built by the US government in the veteran hospital system in the 1960s. And they got it right because one, they said we need this for clinical use. And two, the way it's going to be developed is you're going to have the clinician and the technologist work together to actually get it right. And the VA system is exceptionally good clinically. But unfortunately, since the clinicians don't call the shots anymore, it's now going to get ejected and it's going to be replaced by a vendor system, Cerner. Cerner is probably one of the worst systems developed in terms of the EMR, but that's what I think the NHS also is going to use, right? So you have to be really careful that I think you really need to have the funders, the users, and the technologists working together. Otherwise, you're going to get problems. And I think the focus also has to be broadly on improving health. And the best way to improve health is really beef up preventive care before you get into curative care.
For the few who don't know Shyam, he's the Associate Professor of Department of Biomedical Informatics at the University of Pittsburgh School of Medicine. And he's been, he's really into technology since many, many years ago. And so any of you want to respond to Shyam? Otherwise, we are kind of running out of time. We'll close in 3 minutes. If anyone has any questions or comments, please go ahead. Radhakrishna, you want to say anything? I thought this session will be one of the shortest ones, because, okay, Shivam will say something, everyone will listen, nobody will know anything, so they'll ask nothing, and we'll probably wind up too early. But completely opposite, it's generated so much of discussion and so much of debate. So, Radhakrishna, your...
listening to Shivam, this extreme, and my teacher Anand Krishna, other extreme, and everybody in between. I'm really, really jinxed. Actually, I should admit that I'm one of those incapable doctors who couldn't motivate their management to, invest in digital health. And for some reason, many of these corporate people don't seem to be serious about it, and a lot of our documents are written in Word documents. There's no data, and as Sumant often says, that there should be a legislation coming in and force everyone to get into this. When we have our railway system digitized so well, when we have our land registration digitized so well, I'm surprised that the health system hasn't, maybe it doesn't get any money or whatever. It doesn't seem to happen, because we've seen so many things happening these days in digitization, excepting in medicine. And I'm sure a day will come where the government should be very strict with a carrot and stick policy, that if you don't listen to us, you don't exist. I think once, and again, Sumant always keeps saying that we doctors have to carry that momentum, which we don't seem to. And, we take it easy. We're not bothered whether, we want to spend our time in clinical medicine, make our money and get back home and not really bothered about what's happened to the future of Indian medicine. Yeah.
Dr. Anandkrishnan, you want to say anything, sir? You said you had something to say in the end. Yes, Kaveri, please unmute yourself. Kaveri, unmute yourself.
I'm very glad that my brother spoke very well, and I want to tell him that already India has started digitalization in healthcare. I am an ESI, and all of us are using computers for putting our information, diagnosis, everything. As Natarajan said, it is useful for chronic cases, and for acute cases, it is a little difficult at a very early stage we are. And I want to give promising words to my brother that we should start digitalization in healthcare, and it will pick up the momentum he has started. It will pick up, and in another 10 years, you will see that we will shine better than the
Saudi Arabia.
What is required, I want to tell at this point of time is, what is required is we are interested, the doctors are interested, much more are our patients. Our patients use phone nowadays. I speak in the phone and follow-ups are done on the phone many times. They're unable to come because the cost factor of reaching the hospital is very high nowadays, and it is much more than the medicines that they buy. So that way, on digitalization, many things can be done. And with India being the capital of diabetes, and me being a diabetologist, I want digitalization so that we have 100% care for our diabetes. Because as said, it is there in our genes, being an Asian and Tamilian or even an Indian, we are prone for diabetes. But if we want to give full care for diabetes, I want digitalization, which is going to bring a lot of changes. What is the drawback here is our politicians, our administrators who want to eat on the even paltry, our budget spent on health is very less. But even from that budget, our people wanted to put a craving for bringing in more machines. They are more craving for building more hospitals because they can take commissions or in the tenders that they give. Rather than in maintaining, administration is lacking in that. Our administrators are good, but they become corrupt because there are people who are trying to buy the administrators. They wanted to eat on the money by building more hospitals rather than bringing healthcare for the people. Especially for, in India, prevention care is very well developing. All our doctors are going on, campaigns and many things like that, like creating awareness in our public. So our people who, without even much education, they are becoming more forward in learning many things in health, and they're very, very interested. What is required is a very sincere attempt in bringing about all these changes. And unless these, we have some crooks who are going to be they are the people who are spoiling all these things. There are good people, there are bad people too. But these bad elements, especially among our administrators, they are interested in building more and more hospitals. In Pondicherry, how many hospitals? Every street is having a medical college because they want to invest in buildings. Take more in that. But in maintaining it, nobody wants to come.
Kaveri, your point is well taken, and I'm sure all of us agree with you that we need to look at problems.
I may be held up for speaking these words, but then these are the true words, and I can point out. For the last so many years, how many people have been caught? This is the biggest thing is the drawback in India. Health is not improving. Is many things like this are there. Otherwise, digitalization will happen in India, and we will be better than what my brother said is happening in UK and in UAE countries. because we are pioneers in many things. So India will shine. I'm giving promising words. And thank you, Shivam. It was wonderful. Thank you, Vidya. This is a very nice, LGS programs are very nice. Thank you.
Dr. Sushma, did you want to say something? Please unmute yourself. Please unmute yourself, Dr. Sushma. Your mic is off. Dr. Sushma, your mic is off. Yes.
Am I audible?
Yes, yes.
Congratulations. I think it's a very good food for this thought. I think we should all go for it and be the latest, and advances can be made only when we do digitalization. I think it's a very wonderful program. It really stimulated me so that we go on to the best of the technology which is available anywhere in the world. So congratulations. I thoroughly enjoyed the session. Thanks a lot.
Thank you. Shivam, totally your ageism thing is knocked off.
I was not being ageist, so sorry about that comment.
I'm just kidding. I'm just kidding. Any closing comments from you? We are really run out of time.
Thank you for this opportunity, and I didn't expect this much of debate, but the very fact we had this discussion and debate, it indicates the engagement, and that was my intention. So I'm happy with that level of engagement, and thank you, Vidya and Dr. Radhakrishna, for actually giving this opportunity. And this is a wonderful platform, and hope we will see a lot of it. Is the digital platform has enabled this, so let's celebrate the digital way of learning.
Sumant, your closing comments, please.
Let me unmute myself. Yeah, I think first of all, it's been a fascinating session, and listening to so much of expertise coming in from different parts of the world from so many people. So thank you for having given me the opportunity to participate, and it's been a pleasure to share my experience and thoughts on this program.
Thank you, Sumant. And I convey my apologies on behalf of Dr. Kishorupal. He had some, I don't think anybody thought it will go on beyond 10:15. Thank you, Dr. Ananthakrishnan, for joining and staying through more than 2 hours of discussion. And we still have about 18 people still on the meeting. So we'll meet again. Probably what this shows is probably we need to take up this topic in some other way another time. So in a few weeks or months' time, I might be reaching out back to you, Shivam. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.